Alrighty, good morning everyone. Thanks for taking the time out of your morning to tune in. Today I'll be talking to you guys about glenohumeral dislocations in the emergency department, or more simply put, shoulder dislocations. Before we get started, there's a few people I'd like to thank because they were kind enough to help me with this talk. First, I'd like to thank Dr. Eric Mutter, who supervised this work. I recently did an elective in pain medicine, and Dr. James was key in providing some regional anesthesia insights for this talk. Dr. Wu was helpful in answering some POCUS-related questions. From orthopedics, Dr. Papp was great in answering a laundry list of questions that we provided him with, and he has especially focused in upper extremity injuries, as well as a friend of mine, Dr. McNeil, who's a community orthopedic surgeon in Nova Scotia. He has upper extremity fellowship training as well, and he took the time to discuss this topic with me in detail. And to my wife, Tanya, who was kind enough to listen to this talk and give me some feedback. So to get started, I think I'd like to talk to you guys about how I became interested in this topic, because admittedly, it's not the most complex topic. But after hearing how I became interested, I think you'll agree that there's some value in revisiting this presentation, as it's by far the most common large joint dislocation that we routinely see in the emergency department. So we're going to go on a little trip overseas to Sunderland of the United Kingdom. It's a small city with a population of 175,000. And in 2016, their emergency department completed a departmental audit of their management of shoulder dislocations. And they took a sample of 30 patients with a diagnosis of shoulder dislocation and found an average ED length of stay of 3 hours and 22 minutes. And they found that they were sedating 57% of their patients. Interestingly, they found both of these numbers to be quite concerning and far too high. And this actually encouraged them to enact departmental change because of these numbers. Their solution was simple, and they published their findings in BMJ Quality Open in 2019. They elected to revisit their departmental processes and institute a specific shoulder reduction bench as a means to improve flow and reduce the need for procedural sedation. A shoulder reduction bench had been utilized as the primary method of reduction at the Oxford University hospitals for a number of years, and they found it to be quite effective. They elected to make this the first-line intervention for all anterior shoulder dislocations within their department. For this, the patient is situated in a chair, and the practitioner initiates downward traction with the addition of supination eventually, and reduction is completed without the need for IV procedural sedation. The results were quite striking. Through initiation of this simple shoulder reduction bench, they were able to reduce their average length of stay by 52 minutes, or 26%, and decrease the need for procedural sedation by 68%. Additionally, prior to this, all reductions in their department had been completed by emergency physicians, and for this work, they taught the nurse practitioners in their group how to complete the reductions. Their shoulder reduction bench is now commonly used by nurse practitioners in their group and no longer requires physician presence. To me, this was a pretty striking result, and it led me to think, what are we doing at the Ottawa Hospital? Unfortunately, I didn't have the time to complete a retrospective cohort study, but Miguel gave me the idea to look at our billing data as a surrogate marker to get a sense of our practice pattern. And from OHIP, there are two codes that can be billed: D015 for reduction without anesthesia and D016 for reduction with anesthesia. Over a 1-year period, we saw approximately 219 shoulder dislocations, which amounts to a couple every week at each campus. If we assume perfect billing, this results in a sedation rate of about 64%, which is exactly 7% higher than the alarming rate in the previous work that prompted complete departmental process overhaul. And so, after seeing the magnitude of our own sedation rate, I thought this would be a good opportunity to revisit this common presentation and to think about how we can potentially improve our own throughput and efficiency. So the objectives for today are as follows. We're going to discuss a variety of topics, and they'll be akin to how a patient may flow through the emergency department, with a primary focus on anterior dislocations. I'd like to discuss the utility of pre-reduction x-rays and discuss scenarios where they can be perhaps deferred. POCUS continues to grow in popularity, and we'll discuss how this can be utilized in the diagnosis and management of shoulder dislocations. We'll review procedural sedation alternatives, specifically intra-articular lidocaine and 2 other forms of regional anesthesia. And we'll also review some shoulder reduction techniques, and then discuss some techniques that have been employed that alleviate the need for procedural sedation. We'll also review immobilization and appropriate follow-up care. And then finally, we'll briefly discuss posterior shoulder dislocations, and I'll provide some insights that will reframe your approach and help you to not miss this uncommon presentation. All right, pre-reduction x-rays. So traditional orthopedic teaching would suggest that both pre- and post-reduction films are required. In practice, however, I have seen varying approaches among staff, and can't say that I myself had a good approach before reviewing the literature. As we approach this subject, I'd like you to think about 2 clinical scenarios that I've encountered recently on shift. The first case involves Jane. She's a 17-year-old female that presents to the ED with a suspected right anterior shoulder dislocation. This has happened multiple times in the past, and she typically presents to the ED for assistance with reduction. Today, she was in math class when she simply raised her hand and unfortunately dislocated her right shoulder. The second case involves Bob. He's an 18-year-old chap that presents to the ED with suspected first-time shoulder dislocation. He was at football practice performing contact drills when he was tackled by teammates and felt a sudden pop. Would you image either of these patients prior to reduction? Keep this in the back of your mind as we proceed forward through this section. The first study that I'd like to highlight comes from the American Journal of Emergency Medicine in 1999. This was a Canadian study out of Banff, and they set out to identify the utility of pre-reduction imaging in patients with suspected shoulder dislocation. Amongst the 97 patients in their cohort, the decision to undertake pre-reduction imaging added on average 30 minutes to the departmental length of stay. If imaging hasn't been ordered at triage, I think this intuitively matches the way I've seen patients flow through our department, where you'll assess them, order some imaging, and then go off to see another patient while the confirmatory x-ray is performed, and essentially add 30 minutes to their department length of stay. Another Canadian study out of St. John, New Brunswick, published in the Emergency Medicine Journal in 2015, in this retrospective work of 106 shoulder dislocations, they were successful in reducing 97 of them on the first attempt. They found that for each additional 10 minutes that a patient was in the department from arrival to first reduction attempt, this increased the chance of reduction failure by 19%. So we see that pre-reduction films increase length of stay, and delays in reduction can increase chances of reduction failure. So this gives us some support as why we may want to defer imaging, but it still doesn't quite answer the case when pre-reduction imaging can safely be avoided. In a retrospective work out of New York in 2009, Orlowski retrospectively examined the records of 7,209 patients who presented with shoulder dislocations. For patients under the age of 30, fractures were exceedingly uncommon and occurred in less than 1% of cases. And in moving forward, in a study out of California in 2000, they completed a prospective cohort study at a level 1 trauma center, and in 76 patients presenting with a suspected first-time dislocation following a blunt mechanism, 10 of them were found to be fracture dislocations. So this suggests that when patients present with any element of trauma on clinical history, pre-reduction films cannot safely be avoided. So building on these previous two studies, we're fortunate enough to have a clinical decision-making rule that incorporates findings from the previous 2 works. In 2018, Amand and colleagues published a clinical decision-making rule which combined 2 previous rules into one, the Fresno rule and the Quebec rule. They performed a prospective study in the ED of 2 level 1 trauma centers, and their goal was to detection of clinically important pre-reduction fracture dislocations. where clinical importance was defined essentially as anything that might influence ED care or follow-up. This essentially amounted to any fracture except a Hill-Sachs lesion. The rule is outlined as follows. Atraumatic recurrent episodes do not require imaging. Age and mechanism are then incorporated to make further decision regarding imaging, where imaging is again deferred for young patients with atraumatic mechanisms. The rule is found to be 100% sensitive and 50% specific. And in this cohort, they found that they could reduce pre-reduction films by 44%. Of note, this rule has been retrospectively validated in a recent Turkish study, again demonstrating 100% sensitivity. However, it has not yet been prospectively validated. However, I think this is a reasonable and practical framework that can easily be implemented on shift to expedite reduction. And if there's ever any clinical concern, you could continue to get an X-ray. So for Jane, her presentation with a simple atraumatic and recurrent mechanism does not require pre-reduction imaging. And for the case of Bob, he's less than 35. However, his contact and sports-related mechanism warrants imaging to rule out fracture dislocation. The take-home point number one, pre-reduction films are not required in all cases, in particular in recurrent presentations and young patients with atraumatic mechanisms. Consider utilization of the Fresno, Quebec rule to help guide decision-making. And however, if a patient doesn't fit into one of these categories, or if there's clinical concern, I would deviate from this protocol and obtain a pre-reduction film. Okay, so POCUS. So building off our discussion of pre-reduction imaging, I'd like to discuss the utility of point-of-care ultrasound. POCUS continues to grow in popularity, and recently there's been a fair amount of buzz around how it can be applied to shoulder dislocations. At this time, it's not formally taught in our POCUS curriculum. However, it's a pretty easy to learn technique, and so I thought I could provide a brief overview of how it's performed and then discuss some of the evidence of how it can be applied clinically. Most commonly, the curvilinear probe is used, and it's placed in the posterior aspect of the shoulder in the transverse orientation. This is an example of what you'll see on imaging, and is an example of a non-dislocated shoulder. You'll see the humeral head articulating with the glenoid, the scapula medially, and the infraspinatus moving above as the patient internally and externally rotates their arm. Conversely, in this case, we see that the humeral head is no longer articulating with the glenoid space and represents a shoulder dislocation. As we are using a posterior approach with the ultrasound, for an anterior dislocation, the humeral head will appear at a greater depth on our screen. And in the case of a posterior dislocation, the humeral head will appear at less depth. If there's any ever confusion, you can always compare with the anatomy of the other side. And so now that we have a basic understanding of how exactly this works, let's dive through some of the literature on this topic. In 2019, Gottlieb published a systematic review in the American Journal of Emergency Medicine. They sought to compare the diagnostic accuracy of ultrasound compared with plain radiography in the assessment of shoulder dislocations. They included 7 studies comprising 739 assessments and 306 dislocations. Overall, ultrasound was 99.1% sensitive and 99.9% specific for the diagnosis of shoulder dislocation. They also make claim that ultrasound is highly sensitive for fracture identification. However, few of the included studies were actually fracture dislocations, so it's difficult to place a ton of weight in this claim. Building off this work, I'd like to highlight one paper in which many of the patients did have fracture dislocations. In a 2020 paper by Secco in the Annals of Emergency Medicine, they also examined the utility of ultrasound for dislocation diagnosis. Amongst their cohort of 65 patients, there were 25 total fractures, and 48% of them were not identified by ultrasound. Now, they present this in a more positive light and remove the clinically insignificant fractures from their calculation, and then requote the sensitivity as being much higher. But I disagree with this positive spin, as one of the misses was a surgical neck fracture of the humerus, which is one of the major contraindications to reduction attempt, which we'll discuss later. So we've covered some of the literature. How do you integrate this clinically? So we have Glenn. He's 65. He's presenting to the ED with a traumatic shoulder dislocation confirmed on pre-reduction imaging. It's a very difficult reduction requiring sedation, and you think you felt a clunk, but given his large body habitus, you're not really certain. This is where ultrasound can come in. You grab the ultrasound probe and confirm successful reduction at the bedside. The patient is then sent for post-reduction imaging, and you have avoided the need for repeat procedural sedation and prolonged occupancy of a monitored bed. So take home point number 2. Ultrasound is a readily learnable skill. It's great for diagnostic confirmation, and it can assist in the confirmation of reduction in those difficult cases where you're not sure if your reduction was successful. You likely don't need it in the overwhelming majority of cases, and it will miss fractures. So I don't think it replaces the need for pre-reduction imaging when indicated or standard post-reduction imaging. Okay, for the next section, I'd like to discuss some alternatives to procedural sedation. In our current working environment, cardiac monitoring is becoming more and more precious, and it's a difficult commodity to access. So I think it's an important topic to at least be familiar with. For this case, we have Bob. He's a 70-year-old male presenting with a recurrent shoulder dislocation. He's presenting 12 hours after an atraumatic dislocation. He's a notoriously difficult reduction, and you feel as though he'll benefit from sedation to facilitate your reduction attempt. You contact the CEF to have him moved from urgent care to resus. However, there are no monitored beds available, and they state that it's going to be a while, maybe 2 hours. This has you thinking, are there any alternatives to procedural sedation? Within the literature, there are 3 forms of regional anesthesia that are commonly cited as alternatives to traditional procedural sedation. We have intra-articular lidocaine, the suprascapular nerve block, and the interscaling block. To simplify things, we're not going to discuss the interscaling block in any further detail. On my most recent pain medicine elective, Dr. James and some of the other pain medicine physicians thought that it was an unnecessarily complicated and higher risk block and no more effective than the other alternatives available. So we're going to focus our attention to intra-articular lidocaine and the suprascapular nerve block. So for the suprascapular nerve block, it is commonly described in the literature. However, I have not seen this routinely used amongst our group. For this procedure, you'll utilize some of the ultrasound anatomy that we covered previously. It's a sterile technique performed under ultrasound guidance. A spinal needle is used, aiming towards the joint space, where 15 to 20 cc's of 1% lidocaine are injected. On the left, you'll see the typical procedural setup, and on the right, it is an example of the procedure being formed under ultrasound guidance. The big concern that comes up with this is regarding the concern for possible chondrolysis, loss of articular cartilage, secondary to the lidocaine. This has primarily been reported in the literature in the setting of post-operative infusions, and there's little data regarding what impact it has on the current proposed application. In discussion with both orthopedics colleagues, they felt as though single injection use was safe and did not feel as though this would prohibit use in the emergency department. In terms of evidence, in 2014 in the Journal of Clinical Anesthesia, Zhang and colleagues published a systematic review comparing intravenous analgesia and sedation to intra-articular lidocaine. They were able to include 438 patients with 9 studies with varied methods of sedation and reduction technique. No significant difference was found in joint reduction success, with sedation being associated with more adverse outcomes such as respiratory depression, vomiting, and thrombophlebitis. A previous Cochrane review from 2011 also found similar results. And so I think intra-articular lidocaine emerges as an effective procedural sedation alternative. All right, next we'll discuss the suprascapular nerve block, which has been described in the literature to aid in reduction attempt. It's routinely used by Dr. James as part of his pain practice, but he's also used this several times successfully in the emergency department to facilitate reduction. The suprascapular nerve itself is a mixed nerve containing both motor and sensory fibers, originating from the superior trunk of the brachial plexus, the C5 and C6 nerve roots. It passes through the suprascapular notch, and it is this that is utilized in ultrasound to help with identification. The procedural setup is similar as we saw with intra-articular lidocaine. However, the ultrasound probe is now more medial and superior along the scapula. A simple landmarking technique is demonstrated above. The trapezius is outlined in addition to the superior aspect of the scapula, with the ultrasound placed in the groove formed by their connection. In the above photo, we see the suprascapular notch, the primary target, and the overlying transverse scapular ligament, which is hyperechoic. The suprascapular nerve is located just beneath this ligament. The suprascapular artery and vein are close by, but they fall above this ligament, and Doppler can be utilized prior to procedure to make sure they are avoided. On the left, we again see an example of the suprascapular notch with the overlying transverse scapular ligament. In this technique, a spinal needle is again employed, and the goal is to dip below the transverse scapular ligament and bathe the nerve with approximately 5 cc's of 1% lidocaine. Now that we understand how this block is performed, how effective is it? The literature surrounding this technique is far more sparse than that of intra-articular lidocaine, primarily consisting of case reports. In 2014, Tazell and colleagues published a paper in the American Journal of Emergency Medicine comparing the suprascapular nerve block to procedural sedation. This was a prospective randomized trial where 41 patients were randomized to receive IV ketamine or a suprascapular nerve block to facilitate their shoulder reduction using the modified Coker technique. No significant difference was noted in the groups in terms of reduction success. All patients were successfully reduced. ED length of stay was longer in the sedation group. And with this, I think the suprascapular nerve block emerges as a procedural sedation alternative, and it has capacity for uptake amongst our group, given that it is already being employed by one of our local practitioners. So back to the case. For Bob, a suprascapular nerve block is utilized, and shortly thereafter, his shoulder is successfully reduced. He then heads home 2 hours earlier than anticipated, and you move on to your next patient. So take home point number 3. I think for me it's clear that intra-articular lidocaine and the suprascapular nerve block are both effective forms of regional anesthesia and can be considered as an alternative to procedural sedation for difficult reductions performed in our department when monitor beds are less readily available. Additionally, they may be particularly beneficial to ED providers working in smaller community centers where a second provider or RT may not be available to assist with procedural sedation. All right, for the next section, I'd like to discuss some reduction maneuvers. Before proceeding with any procedure, I think it's important to consider contraindications to reduction. The first absolute contraindication is delayed presentation in the elderly, which in discussing with our orthopedics colleagues, we agree that this would be any dislocation that has been present for about a week or longer in an elderly patient. These patients have much higher incidence of vascular injury and fracture associated with a reduction attempt and warrant an orthopedics consultation in the emergency department. The second absolute contraindication is a fracture of the humeral neck. This was a case sent to me by Dr. McNeil from his residency training, for which he was consulted by our RD colleagues in another center following a reduction attempt in the emergency department. On the left, we note a right anterior dislocation. We note that the humerus is impacted and that it has lost its normal contour. It's subtle, but this is suggestive of a humeral neck fracture. Following reduction attempt, we note complete separation of the proximal portion of the humeral head from the distal segment. This is really bad. In an older patient, this is not as big of a deal as they'll likely need arthroplasty anyways, but in a young patient, this essentially gives them a 100% chance of avascular necrosis and means they'll need arthroplasty very early in life. And then one of the most commonly associated fractures associated with shoulder dislocations are those of the greater tuberosity of the humerus. Simple GT fractures in themselves are not a contraindication to closed reduction attempt. However, Dr. Papp wished to emphasize that sometimes a concomitant fracture of the humeral neck can also be present and subtle, and so sometimes they'll actually recommend a CT prior to a reduction attempt if they have clinical concern. So I think practically, in our department, these fractures warrant a call to orthopedics to discuss appropriateness of reduction attempt and for optimization of follow-up care. So this is a case also sent to me by Dr. McNeil. On the left, we note a dislocated shoulder with concomitant GT fracture. A successful closed reduction attempt was performed in the emergency department. And then 2 weeks later, the patient went successful open reduction and internal fixation as an outpatient. So now that we've covered our contraindications, let's discuss various reduction maneuvers that are available at our disposal. There are dozens of maneuvers, and frankly, it can be a bit overwhelming. I think then practically, it may be at least helpful to eliminate a few of these maneuvers from our toolkit as they've been linked to potential harm. So the first is the Hippocratic method, where traditionally a foot is placed in the axilla with traction placed on the abducted arm. This has been linked to brachial plexus and axillary vessel injury, and is such best avoided. This is not routinely used in our center. The second is the popular Coker method, which has been present and in use since 1870. There have been case reports of humeral shaft fractures, axillary vein rupture, rotator cuff, and pectoralis muscle rupture. So given this rare potential for harm, I would defer this technique given the multitude of other techniques available at our disposal. All right, we've crossed 2 maneuvers off the list. Where do we go from here? Well, what's best? So actually recently, Dong and colleagues published a systematic review attempting to answer the question of which reduction method technique is best. This came out in 2021. And they elected to group the various techniques into categories of traction-based techniques, leverage-based techniques, and scapular manipulation. They included 12 RCTs and over 1,000 patients. Unfortunately, they did not find any significant difference in successive reduction, and their results were limited by a small number of low-quality trials. Traction techniques were, however, noted to be associated with less pain, which makes sense intuitively as the application of force may relieve pressure on an impacted humeral head. So knowing that the optimal method of reduction remains unknown, I thought it would be prudent to highlight some techniques that have been associated with successful reduction, with the additional caveat that they can be performed without the need for procedural sedation. As the literature in this domain is quite poor, my criteria for inclusion were at least one study with a fair number of patients and a paper demonstrating greater than 85% success. The first technique is the Davos or Boss-Holzach-Matter method. Boss-Holzach and Matter worked at the Davos Hospital in Geneva and popularized the technique in 1993. This is a self-reduction technique. The patient is placed in the sitting position with the ipsilateral knee raised. The patient's hands are tied together and anchored beyond the flexed knee. The patient then applies gradual traction backwards. The wrists can also be tied to the knee to help the patient, and the head of the bed can also be gradually lowered to assist the patient. Staphylakis found this method to be successful in reducing 86% of shoulders in a cohort of 100 patients without need for sedation and with no associated complications. They didn't record the time for reduction, but other studies have reported an average of approximately 90 seconds. The next technique is the Ferris, or the fast, reliable, and safe method. This technique was first reported by Sayegh and colleagues in 2009. This method employs gentle longitudinal traction accompanied with small oscillatory movements. When 90 degrees of abduction is reached, external rotation is added, with the reduction being achieved at approximately 120 degrees. In their cohort of 53 patients, reduction was successful in 88.7% of cases, with a mean reduction time of approximately 2.5 minutes. And just so the slide would work, I had to put this GIF at 2 times speed. It's a bit faster than, I don't know. The last technique I wanted to highlight was scapular manipulation. The patient is placed prone and with the injured arm hanging over the edge of the bed. There's some variation in how this method is employed, but in general, gentle downward traction is applied by the first provider with concomitant application of immediately directed force on the inferior aspect of the scapula by second provider. In a series of 112 dislocations, Pishman and colleagues reported a success rate of 87.5% success without the need for additional medications. All right, so those techniques are great, but what's your go-to method for the difficult reduction? And we think about Bob from our previous case, a notoriously difficult reduction, whom has been out for 12 hours. You know, you feel as though this guy actually will need sedation. So he's moved to emergent care, and now he's been sedated with a combination of fentanyl and propofol. What would your first attempt be? My approach would be to start with a series of leverage-based techniques. The first being external rotation, which is highlighted on the screen. If unsuccessful with external rotation, I would then transition into a Milch maneuver directly from my external rotation attempt. From the Milch maneuver, I would then apply an anterior directed force on the humeral head, attempting to lift it around the glenoid and back into the joint space. In discussion with Dr. McNeil, he said this anterior directed force has been extremely successful in the times he's been called to the emergency department to assist with difficult reductions. If still no success following this, I would make sure that my patient's sedation and analgesia are optimized, and then consider switching from these leverage-based techniques to a traction-based method, such as traction-countertraction. Here, traction-countertraction is noted. It's ideal to place the sheet on the bed prior to sedating the patient. If no success following this, which should be exceedingly rare, it would then be time to call orthopedics for consultation and consideration for an OR reduction. So take home point number 4. The optimal method of reduction is unknown. Remember your contraindications and arm yourself with a toolbox of maneuvers that can be applied at the bedside without the need for procedural sedation. And then further, have a sequential and stepwise approach for the patient that does require sedation. So the shoulder's back in. What do you do now? Following reduction, every patient will undergo a period of immobilization. Much to my surprise, the optimal method of immobilization remains actually quite controversial. A Cochrane review from 2019 found insufficient evidence to inform the choice of internal versus external rotation for shoulder dislocations. But in discussion with our orthopedics colleagues, they both continue to favor internal rotation, given its relative ease and convenience for both patient and practitioner. So the patient has been mobilized in internal rotation. How long do they stay in this position? In general, approximately 1 week in the elderly. Duration beyond this is associated with increased risk of frozen shoulder, and 3 weeks is generally recommended for younger patients. Practically, you can simply tell your patients to remain immobilized until they are assessed by our orthopedics colleagues and follow up. Patients should be advised to avoid any overhead lifting, and they should be advised to perform gentle shoulder pendulum exercises each day, in addition to elbow range of motion to prevent concomitant elbow stiffness. And a bit to my surprise, both orthopedics colleagues felt as though all shoulder dislocations were appropriate for orthopedic follow-up. Dr. Papp's rationale was multifactorial. He said, in younger patients, they're more likely to be offered surgery and benefit from assessment. For the middle-aged weekend warrior, it allows for a thorough assessment of the rotator cuff that is more difficult during the acute phase of injury. And in the elderly, it allows them to also assess the rotator cuff, but to also assess for a brachial plexus injury, which is more common in this demographic. So they're actually happy to see all these patients in follow-up. To take home point number 5, these discharge instructions are summarized and available in my EPIC phrases. Feel free to borrow my dot phrase, .zm DC shoulder. All right, for the last portion of this talk, I'd like to discuss posterior dislocations. This is a case I saw on shift. It's a 25-year-old male presenting with left shoulder pain. He woke up with the pain after falling out of bed while having a seizure the night before. On clinical exam, the shoulder appears normal. He has somewhat restricted range of motion in all directions, but you decide not to push him any further before you get some imaging. You wonder, is he dislocated? Is he posterior? If he is posterior, this is going to be the guy. Epidemiologic data published in 2013, looking at over 20,000 shoulder dislocations in Ontario, demonstrated that posterior dislocations represent approximately 2% of all dislocations, and classically they're found to be associated with the 3 E's of epilepsy, electricity, and ethanol. Some classic and often taught imaging findings include the light bulb sign, widening of the glenohumeral joint, and the trough line sign. Posterior dislocations are commonly missed, with wide varying ranges quoted in the literature, with some quoting the miss rate to be as high as 80% on initial presentation. Additionally, the commonly taught radiographic findings are difficult to interpret and are often missed. They were once quoted as a diagnostic trap by orthopedic surgeon Harrison McLaughlin in 1954, and this continues to remain so today. Well, what do we do about this? Clearly, this has been an issue for quite some time. Do we just get better at looking for light bulbs? In 2015, Zhu and colleagues published a systematic review of the literature surrounding the diagnosis of posterior shoulder dislocation. They identified 53 articles consisting mainly of case reports and case series that included 242 shoulder dislocations amongst 205 patients. 11.4% had a correct diagnosis on initial assessment. However, in the 36 cases where an AP view was combined with an axillary or Y view or a CT scan, diagnosis was made correct and timely in 100% of cases. In going through these individual cases, it was truly the addition of the axillary view that corresponded to the bulk of this result. To highlight this, we examined the first 2 images, and it's hard to say for certain whether or not a posterior shoulder dislocation is present. But with the addition of the axillary view, we see that there is no question that the humeral head is posteriorly dislocated and that there's impaction on the humeral head. I'd like to highlight one further study briefly because it gives a framework for how to think about this diagnosis. In 2020, Magnuson and colleagues published a study out of a major trauma center in London. Their upper extremity service was concerned that they may be missing a high number of posterior shoulder dislocations. Over a 5-year period, 34 patients were identified amongst their records with a posterior dislocation. They were actually pretty good. All 23 simple dislocations were identified within 24 hours. However, with the 11 fracture dislocations that they had, only 6 of 11, or 55%, were identified within 24 hours, amounting to 5 missed dislocations. 4 out of 5 of these fractures did not have an axillary view performed. And missed dislocations can lead to devastating results, as in 2 of these cases that were missed, the patients went on to develop avascular necrosis of their humeral head. This leads to the additional point that in the presence of a fracture, concomitant dislocation also needs to be ruled out. So as a result of this, they developed a shoulder injury protocol. Now in the work, they did not prove the utility of this protocol. However, I think it provides a reasonable framework for approaching these cases. They stress the importance of the axial view in the initial assessment, and if this is unobtainable, they recommend a VELPO or modified axial view, And if there's still any doubt, a CT can be performed to make sure there's congruency of the glenohumeral joint. The axial review is often not well tolerated by patients, and if so, a Velpo view or a modified axillary review can be obtained as an alternative, as this allows for a more thorough assessment of the joint. The Velpo view is highlighted on the left, and the modified axillary review on the right. So back to our case, we have a 25-year-old male presenting with shoulder pain after a seizure. This view seems pretty reasonable. I don't appreciate any abnormality on the AP view. However, our money is in the axillary view. We note good articulation of the humeral head, ruling out a posterior dislocation. Anteriorly, we note impaction of the humeral head, which is a reverse Hill-Sachs lesion. This suggests that the patient did dislocate posteriorly, but self-reduced prior to ED arrival. So the last take-home point is that posterior shoulder dislocations are commonly missed. Common X-ray findings are insensitive for the diagnosis and will lead to continued routine misses if relied upon. Although this recommendation is largely based on case reports, I strongly recommend that the axillary review be utilized as your best defense against this uncommon diagnosis. So to wrap things up today, pre-reduction films are not required in all cases, in particular for simple recurrent dislocations. Ultrasound can help confirm diagnosis and has the greatest utility for confirmation of reduction. Intra-articular lidocaine and the suprascapular nerve block are effective forms of regional anesthesia and can be considered as an alternative to procedural sedation. There is no optimal method for reduction. Arm yourself with maneuvers that can be completed at the bedside without sedation, and have a stepwise approach for the difficult reduction. And last, common radiographic findings are insensitive for the diagnosis of posterior shoulder dislocations. Utilize the axillary review to improve your diagnostic yield. That's all I got.